Okay, good afternoon to everybody. This is a webinar organized by the European chapter of the Academy. It is inside of the series of webinars that we are doing. You know, we want to maintain with the colleagues around the Europe and worldwide also a connection and debate and also a discussion about the topic that we consider most important for us in the eating disorder field. We want to share the vision of the Academy. That means that we need to accept all the time the fight to offer to our clients the best solution that we can, and so to maintain higher than we can the level of instruction and the provision that we offer to the families and the patient too. And so we have to reflect about ourselves. And today we want to underline the pros and the cons if we work with eating disorder and obesity. Consider that obesity is inside the many activities from different colleagues in different societies and in different countries too. For example, CISDCA, there's the ancient organization that started in Italy for eating disorder from the beginning as obesity inside of this topic of these issues. But it's not in everywhere. There are many countries, and in nosography, the major nosography, DSM, and ICD-11 also, that our obesity is not considered inside eating disorder. And so there are many reasons because we have to be very attentive to the obesity, and there are also perhaps many reasons because we have to be aware to consider obesity inside of us condition. I'm happy, I'm very excited to stay with you because today we have two good presenters. The new line, the format of the eating disorder by the European chapter is to offer an opportunity to stay in touch with one presenter. Today we have two presenters, one in the first part of the webinar and the second in the second part. The first part is with Massimo Cussolaro. She presents his speech, pros and cons with obesity and eating disorders. Massimo Cussolaro is a psychiatrist. He's very important. I love him very much. He said many times, who follow me, he knows that he's the author that I cite more than the other. For me, is the most important professional in Italy for the culture almost. He was founder of the CISDCA. He taught in the University of Rome as a psychiatrist. Now he's in retirement, but he was the founder also of the Eating and Weight Disorder, the journal of the Italian Society, CISDCA, published by Springer. Nowadays, not the editor-in-chief, but he was the editor-in-chief since the beginning until 2 years ago. Now the new editor-in-chief is Lorenzo Donini, but Massimo Cussolaro maintains his practically supervision. He's the supervisor of the professionals in Italy because he's very, very known. I'm very happy to give to him the word. Massimo, it's your time.
Dear Umberto, dear colleagues, thank you. Thank you very much for your kind words, excessive, and thank you for your attention. Now I have to share the screen. Yes. You see?
Yes.
Yes, thank you. Why also obesity? Obesity and eating disorders. My talk is about the possible links between obesity and eating disorders. A necessary preamble. On this topic, I'm partisan. Umberto said that for more than 30 years, I have been part of a group of clinician researchers who have supported the importance of the links between obesity and eating disorders. In 1991, with a group of physicians and nutritionists dealing with obesity and another group of psychiatrists, psychologists, psychoanalysts dealing with anorexia and bulimia, we founded the world's first national scientific society for the study of eating disorders and their relationship with obesity. In 1995, we founded the journal Eating and Weight Disorders, Eating and Weight. The latest books, co-written and co-edited with several friends and colleagues, like Lia Manzato, who is here. Ciao, Lia, and Umberto. These books have also been inspired by the same ideas. Therefore, my talk will argue that eating disorders and obesity, or perhaps better, obesities, are not mutually exclusive conditions. Instead, they are deeply related and connected. The main argument against linkage is the definition. Obesity is defined, classified, and diagnosed on an anthropometric basis. In the current taxonomies, feeding and eating disorders are defined on a behavioral basis, defined, classified, and diagnosed. As a result, feeding and eating disorders are classified among mental disorders in DSM-5, DSM-5-TR, and in chapter 6 of ICD-11. You see, there are 8 diagnostic categories in DSM-5 and in ICD-11, chapter 6, for feeding and eating disorders, but obesity does not appear among them. Obesity instead is listed in chapter 5 of ICD-11 in the section endocrine, nutritional, or metabolic diseases. Diseases? By the way, it may be of interest to note that the ICD-11 itself, when it talks about obesity, calls it a disorder, a nutritional disorder, not a disease. Like feeding and eating disorders. Why a disorder and not a disease? This is because the diagnosis of obesity is based only on a very weak criterion, the body mass index. It may be useful a brief historical note in introducing this topic. A look back shows that some outstanding pioneers in the field of eating disorders were already stressing the importance of links with obesity. In 1932, Moshe Wolf, a psychiatrist, psychoanalyst who died in Jerusalem, described the symptoms of 4 women. Today, 2 of them probably would receive a diagnosis of bulimia nervosa and 2 others of binge eating disorder. The latter 2 with binge eating disorder were also overweight obese and experienced their fat bodies with disgust and shame. In German, ekelhaft, disgusting. In 1959, Albert Stankert emphasized the importance of studying disordered eating behaviors in people with obesity and described 3 distinctive eating patterns: the night eating syndrome, the eating binge, eating without satiation. In 1973, Hildebruch published a famous book entitled Eating Disorders. The subtitle was Obesity, Anorexia Nervosa, and the Person Within. Bruch studied anorexia nervosa and obesity together, always taking into account the uniqueness of each individual case. In 1979, Gerald Russell, in a seminal article, described 30 cases of a dangerous variant of anorexia nervosa, a new syndrome he proposed to call bulimia nervosa. 2 patients out of 30 with bulimia nervosa also had obesity. Finally, in the last 30 years, another new syndrome, firstly described by Leo Spitzer in 1990s, and then received by the Task Force for DSM, binge eating disorder, has connected the medical area of obesity with the psychological, psychiatric field of eating disorders, and contributed to the development of a multidimensional approach in prevention and treatment of eating and weight disorders. Now, a look at the present time, 3rd millennium. Scientific articles and books linking the 2 fields have greatly increased in the first decades of this 3rd millennium. You see how many articles in PubMed contain in the title the words obesity and eating disorders together. And here you see some books for many more on eating disorders and obesity. It has been written that polarization is flawed. And the 2 fields should share research and knowledge to enhance the difficult work of preventing and treating both eating disorders and obesity. Share research and knowledge. Eating disorders, disordered eating behaviors are very common before bariatric surgery and after bariatric surgery, where they are usually underreported. Severe symptoms of atypical anorexia nervosa not underweight, a very interesting clinical picture, can occur in young people overweight or obese who have lost many kilos in few months. The physical and psychological functioning of these young people does not appear less severe than that of adolescents with full threshold anorexia nervosa. But they are overweight or obese, not underweight. In Italy, a recent study confirmed the correlation between childhood obesity and the development of eating disorders at a later age in adolescence or adulthood. This is an American study by Stuart Murray, recently published, and it shows that children aged 9 to 10 years with higher BMI are at elevated risk for disordered eating behaviors. Already children of 9, 10 years old. According to a very recent review just published a few days ago, abuse, trauma, and childhood obesity are strongly linked to eating disorders. Lastly, another review published 2 years ago showed that obesity and eating disorders have a two-way impact. Obesity is a risk factor for eating disorders. Eating disorders are a risk factor for obesity. Indeed, there is a common background. As to background, a brief epidemiological note may be useful. Over the past 40 years, the prevalence of obesity in the world has increased roughly threefold in adults and more than eightfold in children and adolescents. Why? Obesity rates created a endemic condition. An excellent study by Fabrice Etilet and Lisa Oberlander concluded that the rising obesity rates are essentially explained by a rise in calorie intake associated with global changes in the food supply. Food has become more abundant, more available, cheaper, richer in fats, sugar and sodium, lower in fiber. Some foods with these features are called addictive foods. After all, let us think about the etymology of the word obesity. Obesity comes from the Latin obesum, that is, because of what has been eaten, edere esum. The pandemic explosion of obesity and the spread of abnormal eating behaviors are inscribed on a common background in which conflicting forces are operating. overflowing supply of food, decreased energy expenditure, glorification of lean and muscular bodies, dietary healthism. Such forces promote weight gain, body dissatisfaction, dissatisfaction with one's physical appearance, and abnormal ways of relating to food, weight, and body shape. These forces act at conscious and unconscious levels with effects related to each individual's life history and personal, genetic, epigenetic, and psychological structure. Non-homeostatic eating disorders I call eating patterns where calorie intake is more or less than energy expenditure for life and for growth during childhood and adolescence. The stigma of obesity, the social and internalized stigma, contributes to the development of eating disorders, of course. In fact, there are many similarities in the risk factors, such as low self-esteem, external locus of control, abuse and neglect during childhood, dieting, media exposure, body image dissatisfaction, weight-related teasing, shared susceptibility genes, and similarities in phenotype, such as excessive attempts at weight control, binge eating behaviors, food craving, addiction, and so on. The same eating patterns are found to be transdiagnostic across the spectrum of eating disorders, from anorexia nervosa to binge eating disorders, and along the BMIs, from emaciated bodies to very severe obesities. In addition, there are similarities in treatment. In many cases of obesity and eating disorders, the intervention should be multidisciplinary, coordinated between different services, and similarities in team composition. The ideal treatment team has a similar composition: dietitian, nurse, physician, psychiatrist, psychotherapist, psychologist. Recently, a Canadian group published a very interesting paper with the results of the REAL study to propose an integrated psychosocial model. The study provides evidence for an integrated psychosocial model consisting of socio-environmental, psychological, and behavioral factors that may best explain the complex interplay of risk and protective factors that influence eating disorders and obesity. Integrated psychosocial model to explain the etiology of eating disorders and obesity, to contribute to explain. This is the results. REAL is the acronym for Research on Eating and Adolescent Lifestyle Study, And you see there are stressors like weight teasing at level of family, peers, adults, negative life experiences, and diet aspects of diet culture with internalized ideals, aware ideals, and tendency to restrained eating. These factors influence lifestyle and emotional regulation that are very important factors that influence in a complex interplay body image, dysregulated eating, and contribute to cause obesity and eating disorders or disordered eating behaviors. The real study has given a robust statistical evidence to an integrated model of risk and protective factors that influence the development of both eating disorders and obesity in a complex interaction. To conclude, I think that we should talk about obesity and eating disorders as two sides of the same coin and use a comprehensive expression such as weight-related disorders, or perhaps better, non-homeostatic eating disorders. As a general principle, we should remember that taxonomy divides, nosology studies linkages, connections. In recent decades, there has been an over-reliance on diagnosis-based research and clinical protocols. Too much importance on diagnosis. We have forgotten the weakness of many current diagnostic definitions, including those of obesity and eating disorders. The consequence has been the gradual disappearance of the person behind the various symptomatic uniforms. The person within, is said Hildebruch. But it is a long road and we are only at the beginning. Thank you.
Thank you, Massimo. As always, you are very exciting, and so it's very important for us to follow your thinking. And we have the opportunity to reflect because you open many, in deep way, many aspects. You don't speak concretely, Massimo, about prevention, for example, you underlining why it's better in the school to produce in the same time prevention for obesity and eating disorder. For example, you can say another 2 words about it.
Absolutely. I did not speak about prevention in details for time limitations, of course, but for example, Neumann Steiner, who published a number of papers in eating and weight disorders to the Journal of CISDCA, Neumann Steiner is a researcher and a clinician who supported the necessity of integrated programs for obesity and eating disorders, because we should avoid the risk of using conflicting messages to prevent obesity and enhance the development of eating disorders, or to prevent eating disorders and neglect the risk of obesity. But these integrated programs for prevention are very difficult, and it is especially difficult to evaluate the effects, because long-term longitudinal studies would be necessary on a great number of children.
Thanks, Massimo. Everybody can pose this question also by using the last part in the middle part of the screen, the opportunity to pose question written. Otherwise, you can take the words, open the micro. I want to use this moment to underline the opportunity that me personally, and the European chapter has to receive the support by Elisa Meyer and Dawn Gordon. They are very friendly American friends and colleagues and experts that help us to become stronger. Without them, it's impossible for us to produce what we are doing. Thanks, Elisa, and thanks, Dawn.
Precious support.
It's a precious support, exactly. It's much more than precious.
Much more. And valuable.
Exactly. Other question?
There is a chat.
There's a chat also, if you want to write.
It's our pleasure by Dongan.
I want to link, Massimo, I want to link more obesity and pandemic, because pandemic changed many things in the world, no? And so they changed the behavior, it changed the, okay.
COVID.
The COVID, we use many times the word syndemic, because there are many pandemic. Pandemic for by COVID is one. Is what happened at the new stores. But there are other aspects now that produce this kind of syndemic. And the connection between syndemic or pandemic and obesity is, in your view?
Oh, what? Yes. There are many studies that show that during lockdown, for example, obesity and eating disorders increased. The word syndemic is used to underline, to highlight the interactions between different pandemic phenomena that worsen one another. And during COVID-19, cases of obesity and eating disorders increased.
If there aren't other people, I will pose another question, Massimo. You find that there are some different attitudes from the therapists to assess people with obesity and people with restrictive behavior. You have to have some moods, some attitudes, some personality aspects that help you to get in touch in deeper way with the obese and the other part, for example, anorectic people, or we are the same all the time?
No. Of course, an important difference is that obesity is an enormous phenomenon. present in many countries. More than half of the population is overweight, obese. For this reason, I think we should speak of obesities, not of obesity. Obesity is an umbrella that cannot contain very different clinical pictures and situations. Anorexia nervosa, bulimia nervosa are more distinct and circumscribed clinical pictures with a great psychopathological component that is not always present in cases of obesity, of course. But I think that share research and knowledge in both fields is useful for people who treat patients with eating disorders and patients with obesity. For example, a study on the hunters-gatherers, 400 hunters-gatherers who live in Tanzania, was to read this study, the results of this study that shows that they have a very different lifestyle, of course, but their daily energy expenditure is exactly the same than ours. To read this paper was very useful, for example, to me, to better understand some aspects of physical activity in obese people and some aspects of excessive physical activity in anorexia nervosa. This is a small example of a case about the importance that I think has to share knowledge and research from two fields.
Okay, thanks, Massimo. Last questions, if somebody have to pose a question to him, otherwise we pass to the second part of our webinar.
With Yael.
With Yael, sure. The presenter should be Yael. But if there are somebody other that want to pose a question to Massimo, otherwise, thanks Massimo very much, because as always, your lecture is very important for us. Now I'm very happy to introduce Yael Latzer. She's a friend. She's very, very, very important people inside the European chapter because she's the vice president. She's my vice president. She teach in Israel. She has an history because she is in the medical school of Haifa in Israel, where you receive additional certification in psychotherapy, in family and couple therapies, and in interpersonal therapy. And so she has a very broad, very large training in psychotherapy. She is dean in the School of Social Work at Haifa University and research director in the Eating Disorder Institute at the Rambam Medical Center in Haifa, other one time in Israel. She works in different associations, and she was president also of the Israel Association for Eating Disorder. She received an award by the Academy because she's a very important researcher. And then today, Yael speak about family with obesity, surely, because the topic is obesity and eating disorder. Yael, your time.
My dear friend Umberto, thank you very much for your warm presentation. I approve it, our friendship and our collaboration for a long time. And I would like to emphasize the presentation of my new friend Massimo. It's an excellent presentation. It gave us a lot of food for thoughts. And as an experienced clinician, we always debated between not stigmatize the obese people on one hand, but on another hand, not to underdiagnose them and to give them the right treatment. So it was a very, very interesting and important presentation. And of course, I would like to thank you, Alisa and Don, for the constant help and friendship with the European chapter and all the participants who came from all over the world. So I will be more focused, and I'm going to present treatment for childhood obesity that goes along with part of Massimo presentation, but narrow it to one dimension. Just a moment. So my presentation will focus on the parents as a key player in the treatment of childhood obesity. And my presentation will focus on 4 different topics: an overview, the role of the family in terms of childhood obesity, the treatment options, and the parents as a key player in the treatment. The World Health Organization has identified childhood obesity as one of the most serious public health challenges of the 21st century. As mentioned, childhood obesity is an epidemic that is rising in both industrialized and developing countries. Using the CDC's definition of obesity is off at or above 95 percentile for age and weight, while the prevalence in the United States is about, I think it's much more, 11 to age to 5 to 10, 15, 6 to 11, and 16% age 12 to 19. The National Health and Nutritional Examination Survey indicated that between 76 to 80 and 99 to 2000, overweight has doubled among age 6 to 11, and overweight has tripled among 7 to 12-year-old. As we can see, the red sign is the percentage of the rise of obesity, childhood obesity, and adolescent. So in the USA, more than 30% of children are now with overweight or obesity, with evidence that the prevalence has leveled off. Since 2000, the number of overweight children under 5 around the world has increased by 44%. In 2016, the World Health Organization found that globally, the number of overweight children under age 5 topped 41 million, and the number between age 5 to 19 was 340 million. So it's a real epidemic. You can see in the graph. So according to DSM-5 and ICD-10, obesity is not classified as a behavioral or psychiatric disorder. but rather as a general medical condition, as Massimo emphasized very clearly. However, according to the ICD, obesity accounts for a different diagnosis due to psychological reasons. And according to the DSM-5, binge eating disorders accompanied with obesity is a separate diagnosis of eating disorder. About 30% of overweight and obese people diagnosed with binge eating disorders. But as we understand from Massimo presentation, we have much more among bulimic patients and among atypical anorexia nervosa. So as we can see in the DSM definition, we see more obesity among the bulimia nervosa. 30% of the obese people are diagnosed with binge eating disorder. And we have also in the otherwise specified feeding and eating disorder, we have the night eating syndrome, and we have the atypical anorexia nervosa. Nevertheless, most of the youngest with obesity suffer from some emotional, social, and interpersonal difficulties beyond their medical problems. Researchers indicated that youngsters with obesity are more likely to report serious emotional problems than non-obese youngsters. Girls with obesity are more likely to have attempt suicide than non-obese girls. Adolescents with obesity engage more in unhealthy behavior and experience and more psychological distress than their non-obese peers. Children with obesity who seek treatment showed increased level of depression, which is very high, 48%, 35% anxiety, and 30% somatoform and eating disorder. Thus, the call for effective treatment and prevention is urgent. So what are the treatment options for childhood obesity so far? So we have the option of behavioral treatment. This is the most popular, like Weight Watcher, what we call them, nutritional treatment, pharmacotherapy, surgical intervention, psychotherapy, intensive inpatient therapy for severe morbid pediatric obesity, social intervention and prevention, and the family-based treatment. Unfortunately, most of those treatment modalities were proven to be ineffective, both at the therapeutic dimension and the maintaining dimension, and of course, at the prevention level, with an exception, minor exception, of the family-based treatment. And I will focus on the family-based treatment. So the most effective approach was found to be one that involves the family, in particular, the parents. The rationale for involving parents in the treatment is based on the systemic theory and the etiology and prevention of childhood obesity. So what is the family and the parents' role in the etiology and prevention of childhood obesity? So let us understand this first. So the psychological problem of childhood obesity are correlated with parental psychiatric symptoms, with parental eating and activity behavior, with parental obesity, with parental over-controlling food intake, with parental socioeconomic status, and with parental criticism. It's rather than with age or gender. parents tend to either deny or criticize the overweight status of their child. And they tend to underestimate the difficulties involved in changing eating behavior. They blame the child. It was found also that neglect among children is associated with a 9-fold increase in the likelihood of childhood obesity. Family theories suggest that the child with obesity plays a special role in the family. This is according to the systemic theory. He is the identified patient. He has a special role that helps to attain stability in distressed family. His obesity or overweight may be used to distract attention from family's tension issues, such as marital conflict, depression, or worry about illness. The common role are the bad one, the sick one, and the fat one. So if we will conclude the etiology that related to the family role in the etiology of childhood obesity related to parental knowledge, to food selection, to food control, home environment and eating pattern, meal structure, parental as a role model, parents' impact on the child's physical activity, initiation of dieting, and child's body dissatisfaction, the child with obesity as an identified patient. Thus, it was suggested that treatment should target the whole family system, in particular the parents' subsystem. So the family-based treatment for children with weight-related problem. A little empirical evidence. The leading question was, what is the best family approach therapists should use? And what should they focus on? Should they focus on the child only? On all the family members? On both the parents and the child, or on the parents only? The first RCTs performed by Epstein et al. In 1990 and 1994 and 1995 compared treatment that focused only on changing the child's eating habits. This is where the child was the focus, versus FBT combining parents and child. The results show, after follow-up of 10 years, that better result was found in the parents and the child group. Specifically, 34% of the participants who received family-based treatment at the age of 6 to 12 have reduced their overweight by about 20%, with a third of this group being no longer overweight after 10 years. Thus, they concluded that better to treat family than the child during age range between 6 to 12-year-old. Another RCT compared mother with daughter versus daughters only, assessed 55 Mexican and African American girls with obesity and their mothers. The intervention emphasized on eating a low-fat, low cholesterol diet and increasing activity. At the end of 12 weeks, a better result was in favor of the mother and daughter intervention, in terms of the percentage of consumed daily calorie from fat. No follow-up examination was conducted in this research. Another research added 3 more variables to better weight loss outcome, to the extent of family functioning, to the positive support system within and or outside the family, and to developing a positive self-image. They also didn't have a follow-up result, so although the results were very in favor of the family treatment, still there is no follow-up. Hugs added 1 more question. What is the best way to treat your child's eating? And she focused on the control of the parents, over-controlling versus no control at all. Her result indicated that parents who impose control on their children's eating, that is strict authoritarian parental behavior, interfere with the child's ability to regular food intake and to be far beyond their internal cues of eating. It may result in increasing the risk for later development of binge eating behavior and overweight. In contrast, parents who are authoritative, who used authoritative strategies, meaning boundaries, but with a very sensitive and not controlling way, along with facilitating appropriate child autonomy, enable the child to regulate his own eating behavior. Their recommendation was not to be over control over the child's eating. It goes along with many other research. So what we have learned so far, that parents should be involved in the treatment of childhood obesity. Parents should use authoritative strategies rather than strict authoritarian food control. Yet there was no consensus as to how parents should be involved. And is the child presence and responsibility is necessary? And the main question was, who should be the main agent of change, the parents or the child, or both of them? In order to target these questions, further research was conducted. Moria Golan, she's from Israel. She was pioneering in this field. She conducted few researchers and suggested that parents, rather than the child, should be the main agent of change. In order to answer the question, Golan studied 3 conditions through RCT: targeting the parents only, targeting the child only, and targeting parents with a child. In her studies, Golan used a health-centered, family-based program. She recruited 32 families randomly, a parents only condition versus a child in the parents condition, and the child only. And she assessed weight reduction and improvement of eating-related behavior. What was the treatment basic was included? I will not go through all the intervention, but the intervention is fascinating. The setting is 14 group session, 1 hour each session. The approach is support, and psychoeducation. That's the basic, but it's divided to many phases. The chair was delivered by clinical dietitian, but now we are doing it with psychotherapist accompanied with clinical dietitian. And the topics discussed is limits of responsibility, nutritional education, eating and activity behavior modification, parental modeling, problem solving, and coping with resistance. So at the end of the program, the parents only versus the child only intervention has resulted in significantly greater weight loss in the child, 15% versus 8%. At 1 year and the 7-year follow-up, additional greater reduction in food stimuli in the home environment has also been noted. However, in both groups, the parents' own weight status has not changed at all. We expected to see a change in their weight, but not at all. The dropout rate was 30% in the child-only group versus only 3% in the parents-only group. We can see the graphs here. I will not go inside because I want to leave some time for question. At a 1-year follow-up, the children's only group gained 7% in overweight. The parents only group gained only 3% in overweight. After 7 years follow-up, both group weight status had changed. Again, the children from the parents only group were in better position with 10% overweight in comparison with the children in the children's only group, which has a 17% overweight. Overall result of the family interventions is that the most effective treatment are the intervention that target the parents only, as opposed to parents and child, and of course to the child only. However, it is important to note that the overall success is still disappointing. Even in the best intervention, most children remain slightly overweight. They didn't reduce the weight dramatically. This might lead to conclude that further research still needed to improve the parents-only intervention, aiming to establish a normal body weight and to target some other issue that was not part in the intervention. It is also suggested to target the intervention program as early as kindergarten and not to wait to age 6. And most importantly, not to focus both the problem and the treatment on the child. And this is a very, very important result out of this research. Not to focus the treatment on the child because you add some other psychological and behavioral disturbances. Additionally, we have to remember the role of the environment. So the environment should be targeted much more aggressively in addition to this specific family intervention. Without the environment, I'm not sure we will be able to gain dramatic change. So in conclusion, parenting and feeding style are crucial factors in fostering a healthy eating lifestyle. Parents are the key player in any intervention aimed at the prevention and the treatment of weight-related problems in children and adolescents with obesity. the treatment should target the parents only. And the main techniques suggested for the parents are not non-dieting approaches, no statement about dieting and weight loss. Everyone in the family is included in the program. It's not a program for the obese child. Lifestyle change should be done indirectly by parents only, behind the curtains. The principle of the program lean on. The obese child is not the focus. Parental support, family functioning, the home environment, and good modeling. Thank you very much. This is the take-home message.
Thank you, Yael.
With pleasure.
I was sure that your presentation should be very important, and it is. Thanks. Thanks. I'm excited to listen from you. Questions, please. Otherwise, I want to pose immediately some questions, Yael.
Okay.
For example, because we need to treat a larger family, if there are inside the family, most of the time there are some grandparents and the sibling. 2 words about the 2 roles, grandparents and sibling.
So the main idea of this approach is to target only the leaders of the family. If the leaders of the family is the grandparents, they should be part of the treatment. And the whole idea is to do the work behind the curtain, like by exposing the children to different food, but behind the curtain, to lead different messages, to structure the house differently, to talk about their emotional and feeling towards the obese child, which is one of the main obstacles at the beginning of the treatment. And I think the main obstacle of the treatment is to engage only the parents, because most of the parents prefer that the treatment will be focused on the child, and they are blaming the child by overeating. So if you're talking about multifamily and grandparents, they are welcome to be part, but not the sibling. The sibling should be a sibling. They should remain in the subsystem of siblings, and they should be a support system and not a leaders. We have to create the leadership, the triangle of parents as a leadership who do the work beyond the screen.
Thanks.
May I pose a question?
Please, Massimo.
Thank you. Thank you very much, Yael, for your excellent presentation, very interesting. And connected to my presentation about the links between eating behaviors and obesity and obesum, because what has been eaten. But some questions. First, who is the professional for a family-based treatment for childhood obesity? A psychologist, a dietitian, a physician, a pediatrician? Who is the therapist?
Okay, the first intervention that the research was conducted based on was conducted by a dietitian. That's why the focus was more on nutrition education and nutrition structure and nutrition exposure and how to buy food and how to expose the children into. Now the treatment is more focused, more led by a family therapist that comes, that they are either social work, clinical social worker or psychologist, accompanied with dietitians. So if a psychiatrist is trained as a family therapist, he can do it. If a psychologist is trained as a family therapist, he can do it. Any therapist, if the pediatrician or a family practitioner is trained as a family therapist, he can do it. I think all the profession can do it. It's not a big secret how to do these 14 sessions. And it's very, very, very interesting session and very structured, very easy to lead them. You are not doing any dynamic work. The only a few sessions at the beginning that you give them a lot of support and you try to abbreviate their feeling about their obese child, how they feel disgusting, how they think that they are lazy, etc. You need somebody with more sensitive and a qualification or therapeutic qualification in order to enable them to express this feeling. But the rest of the therapy is very manualized, very easy to do.
Very easy to do, yes. Is a somewhat therapeutic education.
Yes, psychoeducation. Yes.
My question is also for this reason. The high rates of obesity, adult obesity and child obesity challenge the resources of public health. It's very difficult to think that so many families can receive this kind of help.
Because they are too much.
I absolutely agree with you, and this is the big challenge. That's why it has to be involved with three main agencies: to target the media, to target the peer group, and to target the family. You have to deal with three. In this triangle, you have to target the three parts of this triangle. I was focusing on the family because the family did not receive enough attention so far in terms of obesity and in terms of eating disorder in general. And I think talking about prevention of eating disorder, you have to engage the family and to give them a key role. Absolutely. As a role model, as a leading. That's why I was emphasizing on this, not only obesity. You are absolutely right. And I think we don't have to do it individually by separate family. It has to be by groups and to get support from the group. And now it's very easy to do it with the,
as an economic way to
more economic way.
Other questions? Please, you can put it inside the chat or directly speaking. And so writing or speaking, please. There are many friends here. Your view, Yael, your view, what is the weight of the different anthropology to offer the opportunity to become very effective to this model of treatment? Because there are many structures of the power inside the family in the different anthropology.
You know, it's very, this is very optimistic, approach. But of course, the selection of the family is minimal because most of the severe obesity is among a very low socioeconomic family, that they suffer a lot of bringing food to their families. So it will be very, very hard to engage them. Therefore, we have to think, as you said, anthropologically and socially, how to engage them in the community as a group. in order to target and not to ask them to plant vegetables in their garden. It looks pathetic, you know, to ask this socioeconomic, lower socioeconomic status to plant vegetables in the garden.
Other questions?
Question about Israel. Bariatric surgery is more and more used also in adolescents, for example, in the United States. In Israel, it is used.
Unfortunately, Israel is the leading country in the world who use bariatric surgery more than other Western countries. And part of it is related to the fact that it's a free treatment in Israel. And because it's a free treatment, people are...
Free treatment.
Yes, you know, our medical system is very, very good, you know, relatively to many, yes, many other countries, and very organized. Of course, we have some limitation, you know, we are complaining all the time, but still relatively, I think we have a very good medical and equal medical system. And therefore, the treatment is equal for everybody. And bariatric surgery is for free. Some people are going through 3 times bariatric surgery because of medical complication. So that's why we are in the first in the world, but in the last year, the numbers of bariatric surgery reduced because of the new injection.
Yes, liraglutide.
Yes.
Yes.
So many people are using the injection. So the prevalence of bariatric surgery was going down, but still it's very high. And we are more using the sleeves rather than bypass.
Sleeve gastrectomy, yes.
Yes.
But also for adolescents.
And unfortunately, also for adolescents, I don't say that it's the same prevalence, but many adolescents with severe medical complication get the permission to do the bariatric surgery.
Submit to bariatric surgery.
Yes. What is the percentage in Italy?
Percentage,
I don't know the current percentage.
Nobody knows it.
Nobody knows?
No, we haven't an idea, exactly an idea. No, there is the Surgery Association that said how many interventions they did every year. Huh?
But you know, talking about the relationship of obesity and binge eating disorder, the less favored outcome is among those who have a diagnosis of binge eating disorder. Yes. So if we're talking about general outcome after 7 years of 50% good outcome among the bariatric surgery, in particular the bypass, among those who have a diagnosis of binge eating disorder, the outcome is very, very low. So probably you know that.
In Italy, sleeve gastrectomy and duodenal switch are the most used, but rarely in adolescents.
Rarely.
Sometimes, in some cases of Prader-Willi syndrome, bariatric surgery has been used. It's filled in competition with drug treatment. But obesity surgery, I don't know current percentages of interventions. The Italian Society for Obesity Surgery publishes periodically, but it's enough used in more and more. And there are two components. Other interventions are less effective. And people, especially adults with obesity, looks for immediate results.
Yes.
Okay.
Eva want to ask a question. Eva? Yes.
Hi, thank you. It's very good to see you all again in an hour that I can actually make. Well, it's been a long time. I'm always trying to make the meetings. I keep trying every month. I haven't give up yet. But anyways, I'd like to first thank you and Dr. Massimo Cussolaro for the excellent talks you both gave. It's very enlightening and prompts a lot of discussion. And my point of discussion would be, based on your talk, Yael, I totally agree that intervention with the family is the utmost important strategy to render some long-term and some effects. And we try to do that ourselves in our team. But then when we are working with the family, then we encounter other difficulties, and that's this is what I want to ask you, if you have the same difficulties, because usually most of the times families of children or adolescents with obesity or overweight, they themselves have obesity and have problematic eating patterns. And it's very hard, as you all know, it's very hard to change the behavior of the family. Even though this is good for their children, it's not lack of knowledge, but it's really, really hard for us to change the behavior of the family or the parents. And then this would, of course, this won't lead to a significant change in behavior of the children. So a lot of times when we are working with the families, we know that they could be more of help, but they themselves struggle with changing behaviors, changing beliefs, and changing daily eating patterns. And I would like to know if you feel the same difficulty in your countries.
Well, I think, of course, it's absolutely, you're right. And one of the results is that the parents did not change their weight after the intervention, but the children changed. Sometimes you change the whole spirit of the family and you expose them to different pattern without making major changes. So, of course, what you're saying is the main obstacle. So to engage them in treatment is part of it.
Thanks, Yael, for your gentle answer. I'm happy to stop here our webinar because there are many discussions they have to continue, and we have the intention to produce other webinars on obesity and eating disorder in our series. And so stay in touch with the European chapter and follow our webinars. Thanks a lot to Yael and thanks a lot to Massimo. There are very good presentations both. Thanks. See you again.
Thanks.
This March 2nd.
Good night.
Next webinar is March 2nd. See you. Ciao.
Bye.